about the major issue. We want to talk about peripartum hemorrhage. My name is Professor Henrich. I'm the head of the Prenatal Diagnosis and Therapy and Obstetrical Department of the Charité Hospital in Berlin. 210 million pregnancies annually occur worldwide, and 20 million of these patients suffer on maternal morbidity. And it is estimated that approximately 500,000 maternal deaths occur. So 75% of these mothers die during delivery or postpartum. And one of the major issues of these dying mothers is peripartum hemorrhage. Some further numbers. Can you imagine that 4 babies are born every second in the world, and that 4%, so every 25th mother, bleed more than 1 liter during the delivery or postpartum. And this leads to approximately a maternal death every 2 to 4 minutes, with all the consequences for the family, for the kid, for the husband, for the parents, for the sisters, etc. So it's a disaster. Postpartum hemorrhage is one of the 4 major causes of maternal morbidity and mortality, if not the number 1, especially in the low and middle income countries. Every midwife and every obstetrician knows actually that peripartum hemorrhage is due to the 4 important T's. The 1 T for the tone, the 2nd T for the tissue, which means that you have placental remnants in the uterine cavity, or you have placenta bed bleeding due to placenta accreta spectrum. The 3rd T is the trauma. This can occur in the uterus, in the cervix, in the vagina, or in the perineum. And the 4th T is for the thrombine, so clotting disorders. This can be congenital, or they can be also acquired due to medication like aspirin and others. So actually every midwife and obstetrician knows about the typical risk factors for peripartum hemorrhage. For instance, multipara, multiple pregnancies, macrosomia of the fetus, prolonged labor, amnion infection syndrome, chorioamnionitis after pre-rupture of the membrane, or polyhydramnios, which occur very often actually, placental implantation disorders, uterine fibroids, clotting disorders, and this can be congenital or acquired. Also, the intrauterine demise or abruption of the placenta are one of the really major causes of peripartum hemorrhage. However, sometimes we have no factors in advance, but the patient starts to bleed without risk factors. And for all of these patients, we have to be prepared, and we have a solution, a very simple solution to stop the peripartum hemorrhage by a chitosan covered gauze, and this is CELOX PPH. In the next minutes, we will demonstrate how simple it is to introduce and to administer this gauze. However, before you start with an introduction of a tamponade, you clarify that there are no lacerations or trauma reasons for the bleeding. Parallelly, you administered already the typical common uterotonics, oxytocin, if available, sulprostone. And in the last years, more or less, we also used tranexamic acid to support the clotting system. However, if all these methods fail, then you have to go forward with the next step of treatment. So now in the next minutes, we would like to demonstrate the application of the tamponade. And before we start, I would like to introduce you to my colleague, Josephine, and to our simulation model. Now, the CELOX tamponade is sterile, packed, and we open it for the assistant. And she is now preparing the tamponade for the insertion. Before, she already clarified that there were no lacerations in the vaginal canal, and she's inserting the speculum. An assistant can hold the speculum, and she will now grasp the cervix with an atraumatic forceps, introduce the gauze gently up to the fundus of the uterine cavity. Now Josephine feels exactly that she fully packed the uterine cavity. She leaves some of the material outside, and in between the next 3 to 5 minutes, the bleeding should stop.
Yeah, very nice contraction, and our gauze is very well inserted. I'm happy.
I want to mention one special issue. In patients with multiples, twins or triplets, or very macrosomic fetuses, sometimes it is necessary to pack the uterus also with 2 gauzes, 2 tamponades of the CELOX PPH. However, it depends on the size of the uterine cavity. Important is that you fully, completely pack the uterus. So now the tamponade is inserted in the uterine cavity, the uterus is packed, and if available, you can check also the right position of the gauze by transabdominal ultrasound. So if an ultrasound machine is available on the labor ward, you can reassure the correct positioning of the gauze by transabdominal ultrasound. So you just put some jelly on the abdomen, and with a regular transabdominal probe, you can visualize the uterus, the uterine cavity, and the correct positioning of the tamponade. On the other hand, you can see if further bleeding occurs or if clots are in the uterine cavity. And very important, for best practice, we recommend the administration of an armband around the wrist of the patient. You have 2 mechanisms. On one hand side, you compress the placental bed and stop the bleeding by putting pressure on the intrauterine cavity. On the other hand, you have the chitosan covered gauze, which stop the bleeding independent from the maternal clotting cascade. And this is one of the very, very important issues. If you have mothers which bleed more than 1 liter, 1.5 liter, or even 2 liters, very often the clotting system is totally disarranged, deteriorated. Therefore, these gauze support the clotting in the area of the placental bed to stop the bleeding. Besides this, you monitor the patient with blood pressure, frequency, and her condition. And this armband should stay for the next 24 hours till you remove the foreign body, the tamponade, and only the one who is removing the tamponade is allowed to remove this armband. This is a very important issue. Besides this, we administer a single shot of antibiotic covering for the patient. In the meantime, the gauze is in the uterine cavity. And then after 12 to 24 hours, we remove the tamponade, which is demonstrated now by Josephine. And this can be also monitored by ultrasound if the ultrasound probe and machine is available, but it's not really necessary. So after the removal of the tamponade, we never have seen any recurrent bleeding. We haven't seen infections and we haven't seen allergic reactions. So it's a very painless introduction of the gauze and painless removal, and we had an extremely highly satisfied patients. One of the major questions is actually the question about allergies. We have not experienced any allergies because the chitosan comes from the shell and not from the meat of the shellfishes. And therefore, we are very happy that also fish allergic patients could actually be treated by the tamponade. So in our extensive clinical experiences and in follow-up studies, we have seen uncomplicated subsequent pregnancies. We have seen normal menstrual cycles. We haven't seen any Asherman syndromes or increased rates of abortions or something like that. So obviously the gauze, and after the removal of the gauze, a normal menstrual cycle occurs and it has no further impact on subsequent pregnancies. We were able to significantly reduce the rate of hysterectomies by 78% since the introduction of CELOX PPH as compared to our previous management strategies and devices. So I would like to add a very important point. Not only does it work as a tamponade, but because of the impregnated chitosan hemostatic agent, it supports clot formation independent of the mother's coagulation factors. And especially the clotting seems to be the problems in mothers which bleed more than a liter or 1.5 liters. So this is, I think, especially in comparison to the other devices on the market, the big advantage. And the application is painless. Application and removal is painless. You do not need any anesthesia or analgesia. And this is also an important issue because it's not always available, especially not in the outpatient clinic setting. So we know from the WHO and from the statistics that the majority of severe peripartum hemorrhage deaths occur in an outpatient clinical setting. That means especially in low and middle income countries, where very often just a midwife alone is responsible for the managing of a delivery far away from a hospital or medical assistance or anesthesia, etc. So to demonstrate that it could be also possible for a midwife alone to solve the problem of severe peripartum hemorrhage, Josephine will demonstrate without any instruments to introduce the gauze in the uterine cavity. Please. So she is taking just the gauze in her hands and insert the gauze manually into the cervix, through the cervix into the uterine cavity, holding with her second hand the fundus and packing the uterine cavity. So because you need not any ultrasound machine or further instruments, you just pack the uterus by your hand and you will be as successful as in the clinical setting. So if the uterine cavity is fully packed, the resistance is palpable in the fundus, you should administer antibiotic single shot tablets as well, but if not available, even it is possible to apply it without antibiotics. So, to conclude, CELOX PPH is the game changer in the treatment of peripartum hemorrhage. I'm absolutely convinced that it will reduce the rate of maternal mortality. So it's time to save mothers' lives. If you need further information, look at the links, and thank you very much for your attention and listening.
Fast-acting, safe, clinically effective, versatile and easy to use at every delivery across the world.